Good morning, everyone. It is an honor to be here today, and certainly my view of the world is much more myopic than what has been shared, but hopefully something that we'll discuss today will be of meaning to you. So, as they've talked about previously today, my topic is the evaluation of options and outcomes in a Me Too market. In the not-so-distant past, this would not have been a feasible topic in the cancer arena. Let's see if I can get this to work. So we started with a polling question that Nicole has put together for us. New oncology drugs being FDA approved are priced at or above current agents within the same category, all have novel mechanisms of action, are driving competition and decreasing cost, are simplifying payer coverage of medications. That was a hard one, wasn't it? So that's absolutely right. They're coming onto the market at or above the prices of agents that are currently available. We could look to the last few weeks, and 6 or 7 new drugs I think have been approved, or we could also look at the last 5 years. And in accumulation, in that 5-year period, 51 new agents have been approved in the space of oncology care. Of those, only about 40% have novel and new mechanisms of action. Oh, can you hear me now? Only about 40% of those are novel and new mechanisms of actions. So what do we take from that? If we look down at 2012, we can see this in full impact. Out of the 11 newly approved agents, only 3 of those were novel mechanisms of action. We had vismodegib for basal cell carcinoma, and then we also have cabozantinib. That was a little bit unique, and it inhibited the VEGF and the EGFR inhibitor. And if we pull out CML succinctly, we look and see there were 2 new tyrosine kinase inhibitors, and 1 agent, the omacitaxine, the first agent approved in CML that was a non-tyrosine kinase inhibitor. So within the course of a year, if we look at NCCN guidelines, we see that our choices for the treatment of CML doubled. What did that do? It took 3 agents to 6, and it also took possibly 2 to 3 lines of therapy, up to 3 or 4 lines of therapy. So how do we evaluate now with all these options? I think at the cornerstone of any P&T committee, we have 3 triads basically that are looked at: the clinical efficacy, the safety and side effect profile, and cost. None of these are easy comparatives. If we look at clinical efficacy, we all know that you can't make comparison among trials. However, most drugs, when they come to market, they're not head-to-head studies. Also, when you look at the variability of endpoints, it's split. If we look at the cohort of these drugs that were approved over the last 5 years, the endpoints were equally distributed. Progression-free survival, or overall response rates were all equal endpoints of these studies. Safety and side effect profile, this is an advantageous point of having Me Too drugs. Each of these molecules, with the distinction that make them a little bit different, they exhibit different side effect profiles. So they can be tailored to individual patients based on their comorbid positions. Cost, as mentioned earlier this morning, we have to look at 2 factors of cost. One is cost to the system, and one is the patient's out-of-pocket cost. If we look going back to this year and the addition, 2012, and the addition of the 3 additional agents for CML therapy, and look to the NCCN evidence blocks, they've added affordability as a comparative factor. Interesting to me was that they didn't make a distinction in these agents. I sign invoices most every day for these agents, and I know there's a cost difference. So I went and looked at AWP, which was not a number I was that familiar with, but certainly how these agents are reimbursed. If you look among the 3 options within the first line of therapy. While this reports that there's not a difference, it is only 7%, but we all know the cost of these agents are pretty substantial, and that absolute number comes out to about $10,000 per month. If we take $10,000, you guys can do this math, right? So times 12 months, we get to $120,000 a year difference for an individual patient. So while CML is not one of our most prevalent disease states, there will be about 6,000 new patients diagnosed each year. So $120,000 times 6,000, you get into numbers that are meaningful pretty quick. $720 million, the cost of therapy for one patient over the course of a year. As Joe just alluded to, the 5-year survival rate for CML is tremendous. About 90% of these patients are going to be alive at the end of 5 years. So we're looking at the prevalence increase of CML to continue to increase at a rate of about 10% year on year for the next decade. Obviously, while the subtle differences of the individual patient cost may not be reported as significant, when you extrapolate that out, the cost to the system can be very significant very quickly. As a pharmacist, I would be remiss if we talked about all of the new approvals over the last few years to not point out the shift in the paradigm and the treatment strategies for the oncology office. We've alluded to a couple of times already this morning that the mainstream media tends to get our message out for us sometime. Certainly this was the case with the new small molecules and targeted agents. We saw headlines like the magic bullets and the miracle pills. This brings another topic into cancer care that's not typically been a conversation point, and that being adherence. With the convenience that these patients have in being able to take medications home with them, they're also taxed with the responsibility of managing their own care. How do we define optimal adherence? We know certainly that there's a correlation between how much medication a patient takes and their outcome. But what's that number? While not a gold standard, most studies look at about 80 to 90% as the goal rate. You might think that that's an easy number to achieve, but if we look at adherence rates overall, oral chemotherapy actually has a lower adherence rate than that of other chronic diseases such as hypertension and hyperlipidemia. Maybe not something that would be automatically intrinsic to our thinking, in that if you would think if you had cancer and were given the opportunity to have it treated as a chronic disease, you would be motivated to take that medication. So what are some of the factors that are contributing to that? Remembering to take your medication tends to be the most common reported, although there are numerous factors that can be intrinsic in this. Most of the time, when this initial conversation about adherence adheres, education is going to be the cornerstone to it, but it's not a very high science. It's just talking to the patient and telling them what once a day means or twice a day means. We live in a world where in meetings like this, the jargon and the medical language that we're accustomed to needs to be broken down for these patients that have a diagnosis that they're now in charge of driving the outcome for. Go through their daily activities with them, help them figure out when is a time that they can remember to take something once or twice a day. How do they need to take it in relationship to food? What about their other medications that they're taking? How do they need to store it? It's education on this level that's going to make a difference for the outcomes. Side effect management is also very important. Typically, when a physician starts a patient on a new oral medication, they're going to bring them back pretty frequent intervals, a week, 2 weeks. But what's going on in between that? What if the patient has the side effect on day 2 and they're not coming back to the physician for a couple of weeks? How are we preparing that patient to deal with that side effect? Do they know it's going to occur? Do they know how to treat it? Do they know when to reach out to the office to get help? And then length of therapy. As we talk about cancer becoming a more chronic disease state, we have to consider that as the patient stays on these medications, they're not visiting the physician office as much. Maybe that relationship is with the specialty pharmacy. Maybe it's with an in-practice pharmacy, such as our office. But we need to develop into the care plan how we're going to continue to engage those patients over that long course of time to make sure that if a therapy is out there that is going to be beneficial to them, that they maintain taking that medication the way it should be. The last factor, and certainly not the least important when we talk about these oral medications, as Jack alluded to earlier, is that they do have the patient incur a higher copay in many instances. The other factor in that is that it's an individual transaction. The IV chemotherapies were received on a monthly bill or a cumulative statement, but this is a single transaction. They certainly know what the cost of that medication is. Do they make concessions, split their doses, skip doses, so that they can afford the next fill or so that the medication lasts a little bit longer? And certainly the timing that we're at today, where we look at benefits changing over the next few weeks as the new year begins, we can never take for granted that what a patient could afford yesterday is still affordable for them as we go forward. Switching back to looking at the options in cancer care, if we look to 2011 in contrast to 2012, all of the agents approved during this year had a novel and new mechanism of action. We had the steroidal anti-androgen for prostate, the drug conjugate for CD30, brentuximab for Hodgkin's disease. We had a targeted therapy in non-small cell with the ALK mutation, crizotinib, the reemergence of the immunotherapies, ipilimumab as a CTLA inhibitor. We had the JAK pathway inhibitor for myelofibrosis. Vanatinib was the specific with VEG, EGFR, and RET inhibition for medullary thyroid. And vemurafenib, that's discussed earlier today too, for metastatic melanoma and the BRAF mutated patients. Small molecules, targeted therapies, we were able to actively pick patients that were going to do better on these medications, match up the best efficacy and predict that. But do we have all the answers? Usually we know what we know, but we don't know what we don't know. In the case of PD-L1, we knew pretty early on what we don't know, and that with the new immunotherapies, we still have some work to be done for the biomarker to determine who's going to respond best to these agents. We can see that in the FDA-labeled indications for these agents. In non-small cell lung cancer, each of the agents are recommended for second-line therapy after a platinum doublet. The difference is that pembrolizumab is only indicated with PD-L1 positive patients, and that their studies showed the best results in patients expressing a greater than 50% positivity. Contrasting that, nivolumab was approved just in a single-arm trial in all comers because of its overall response rate and compared to docetaxel. Similar, if we look at the FDA labeling in melanoma, we see that there are differences in these agents. Both are approved after single-agent ipilimumab or after receiving a targeted therapy if BRAF mutated. Nivolumab has the distinction of also be given in combination with ipilimumab. And then interesting in that NCCN guidelines recommend beyond the label of both these products that they can be given as first-line options. So what do we know? We know that we have newer agents entering into the market. They're providing great benefit to our patients. But if we look at the cost of oncology care, the impact on the economics is certainly undeniable. We see that oncology was one of the main drivers in specialty spend, having the second greatest increase over a 4-year period. When we look at our pipeline, it's not like we can take the agents that we have now and work with them. New agents are going to continue to enter into the market space. If we look at the areas of development, these are certainly our higher prevalence cancers: lung, prostate, breast, colorectal cancer. So there's a lot of work to be done and able to look at these new therapies and get them to their most appropriate patients. We have an aging population. As Julie mentioned last night, more and more patients are being screened. There are going to be more diagnoses. We have expanding lines of therapy. We're getting 3rd, 4th, 5th line treatments in many of these disease states. And we have drugs, while coming to the market at a rapid pace and offering new therapeutic options, they're also priced at a price that's higher than any other sector. Also problematic, as mentioned earlier today, is the fact that the price of these agents and the value they bring is not correlated in many instances. Any new agent entering into the market is priced at a premium to the current, regardless of the benefits or a novel mechanism of action. How do we compare these drugs? How do we measure the value? How do we determine if there's sequencing or if there is a place in therapy to combine them? We have to look at cost to the system in these advances. And maybe clinical pathways will help in putting perspective from the lens of both cost and value in order to help us bring this innovation to our patients where it's going to be able to be the most impactful. So I know there's a lot of conferences that are going on every day. I don't think there's any that have as much impact for us and what lies ahead as to define the value and how it's going to impact patient care. And I think working together, there's opportunities to be able to do just that.